And look at that, we are live in both places. And this is the very lovely Dr. Michelle Griffin, whose name I spelt wrong in the promo. I'm very, very sorry. We used to talk a lot, and we haven't spoken for a very long time, but I've missed chats, and you have moved on, and you were doing lots of exciting things since then. So not only are you an obstetrician and gynecologist, but you've also now started your own company, which does femtech interesting things, which we shall get to later. But before we get to those, we are going to be exploring all sorts of nasty things that can come out of people's vaginas that they're not very happy about. Under the lovely title of "What Discharge Is That?"
I feel like that's like a game show thing, isn't it? Like, what discharge is that? You'll now see some pictures and do on-the-spot diagnoses.
Exactly. And some of these are probably pictures that you don't really want to look at.
No.
Shall we start with some of the very, very common ones? I mean, thrush is obviously one that most people have. Causes, treatments, why does it get worse around menopause? Well, we sort of before menopause, and then seems to drop off mostly after menopause. But so what's going on?
Yeah, it's a really interesting one, actually. And, you know, I was doing some research on this the other day. And I mean, I knew that thrush was super common, but I was really taken aback that it's something like 80% of women will have had at least one episode of thrush in their life. And if you think of that, I mean, it like then that as I said, it's really common. I think you may be listening to this and think, yeah, I've had thrush, or you know somebody in your family or a close friend who's sort of said to you, oh God, I've got thrush, or I must go and get some treatment for it, etc. But when you think 80%, you know, 4 in 5 women have got that. And you just think of the sheer number of women who are experiencing that. It then makes you think that, you know, wow, basically. And then you think about the symptoms. And I think that's the thing that gets it, because it's not typically a kind of, you know, it's definitely not like a kind of 1 hour, oh, it's a little bit painful, but I take a medication and everything's fine. And it's not even like, oh, if I just, you know, change my underwear or something like that. This is usually an episode, is usually a few days. You probably get itching with thrush. That's probably the most common. You rarely see people who've got sort of just a discharge, but it can be like that. But the discharge is very kind of characteristic of what we used to say, oh, it's cottage cheese discharge. So it's a very thick, lumpy discharge. I think that's really good to give that sense of what is it, so people can be more aware. But equally, I think that a thick discharge for someone will be very different for another person. A person could normally have quite thick discharge, and I don't want them to walk away thinking, oh my gosh, I've got thrush all the time. Equally, if you've got quite little or very thin discharge, and then you get a thrush infection, you aren't necessarily going to have a full, thick, yuck discharge related to that. So it's, you know, the key thing with anything when we come and talk about vaginal or vulval health, whether it be discharge, itching, redness, lumps, bumps, anything, is that kind of golden principle of saying, is it different for you? Which I remember we did a live actually a while back about the key message for everybody is you've got to look at what's normal for you, and you've got to know that as soon as possible. So that's a kind of today or this week, examine yourself, have a good look at yourself, have a look in your underwear. What does your discharge look like? How does your vulva feel? What does it look like? Get a mirror, have a look in between your legs. Because if you don't know your normal parameters, it's very, very difficult to then say, is something going on here? And you'll be surprised how many people don't actually ever really kind of take that on board and look at what their normal discharge is and how that changes throughout the month if they are having periods, even if they're not having regular periods. If they notice that the discharge will change where they are, you know, kind of retrospectively look back and think, oh yeah, I did have a slightly different discharge last week, and now I've come onto my period this weekend. If you're having sex, you may notice that your discharge will change afterwards, after sex, and for several days. It may not always, but it can do. So kind of really get to know yourself. And then on that bar, you can then work up and say, okay, thrush would typically be an extreme itching. And the interesting thing with thrush is I was doing some work in this space last year, and I would have thought most people complained of external itchiness actually related to thrush. But I was interviewing a lot of clinicians across kind of GPs, as well as gynecologists in hospitals, as well as pharmacists, to try and get this whole sense of where would different women be going to different places, rather than just saying what would the GPs see, because different women have different behaviors and will maybe just never go to a GP. They feel quite happy about what their thrush symptoms are, and they go straight to a pharmacist. And most healthcare professionals said that actually most thrush presents with internal itchiness, plus minus external.
Couple of centimeters and then itching on the outside as an irritation from it. I would have said just inside the first,
just inside the introitus, the entrance. Yeah. Exactly. So I think that's really interesting. But again, with all of this, I really want to emphasize that if you're listening to this and thinking, well, that's not me, that doesn't mean there's anything abnormal. It's just, we're just talking about general terms here. But the itchiness is probably the number one, closely followed by this very heavy and quite often can be quite lumpy discharge. And of course, the worst thing is that when you've got very itchy external vulva and internally in the introitus inside the vagina, you want to itch it. Of course you do. You want to scratch at it. And the trouble is with that is, one, it causes an awful lot of pain when you actually do scratch that area because it's so sore and inflamed. And not only do you get that extreme soreness and pain from scratching, because the tissue is so fragile at that point, because it's inflamed with this yeast infection, you end up quite often causing some kind of damage to the skin, with little cuts, maybe from your nails or whatever. That then leads to bleeding, potentially, and then you've got this very fragile, inflamed, open skin. And it's just like any other part of our body that, if you cut yourself and then scratch it quite badly, then you're just going to add in more possibility of what we call secondary infection. So the thrush is a kind of yeast infection to begin with. But if you scratch and you irritate the skin more, then quite a lot of the bugs that just live on our hands and is part of normal bugs then enters into these new scratches on the vulva inside the vagina. And that can lead to a secondary bacterial infection. So then a woman saying, look, I've gone from having a very itchy labia and itchy inside the vagina, really uncomfortable. I'm kind of needing to jump in a bath or shower or put some cold press on to get some relief. I have itched it a bit, to suddenly, it's actually, I feel possibly quite unwell. Maybe they've also now got a kind of green-yellow discharge, which is not thrush. This is now a change. This is like a secondary infection. And in that way, you then need to treat the thrush and also the bacterial infection that's come about from itching and breaking the skin and leaving it vulnerable to get another infection on top of the thrush. And then when you go and see your GP or whoever you do, you've then got this issue that, right, we're in this middle of a cycle now, and I don't really know quite where this woman is. And it's like, what do I treat first? How do I get back to the beginning? Because something's led to something else that's led to something else. And often when you give antibiotics, you're changing that natural healthiness of the vagina and the vaginal microbiome. So the normal bugs that we should have commonly, and most of the bugs is lactobacilli, and they're the really good bacteria that we want in the vagina, that are a key function to the vagina in being part of our defense when we're weeing and pooing and having our period and having sex. We need that. But if we take antibiotics, even if we put an antibiotic cream topically onto the area, or we take an oral antibiotic, then we are killing off the bad bugs that have caused the infection, but also the good bugs. And then that leaves us more prone to get more thrush, which often is the beginning issue in the first place. And so women can get into this really difficult cycle that can be very difficult to treat from potentially just one simple thrush episode.
That's not a fun place to be. Which leads, of course, to ask, probiotics then in this case, what evidence do we have that probiotics do work if we take them orally or with a vaginal suppository?
Yeah, so for people who are maybe not so familiar, so you've got probiotics and prebiotics. They're two different types. And, I was going to say of things basically, because as you've said, Fiona, you can take it topically, like if you're thinking about the bugs that live in yogurts, and you're always seeing things like, aren't you, Activia? And I am not recommending you take Activia straight into the vagina, and I will come to that in a moment, but I'm just giving that as an example of probably people have heard of things like Activia and Yakult, and they've got certain bacteria which are very helpful in trying to re-establish the good bacteria. So it's by taking them, you are re-establishing your normal good bacteria that we all should have inside our guts, inside our vagina and vulva, and on our skin. Our vagina isn't unique in that way. We have lots of good bacteria and little mini environments all over our body, serving a really crucial function to lots of different things with regard to our body. And then the other thing is looking at kind of feeding these good bacteria. So this is why a mix of probiotics and prebiotics helps it. Now,
That's
yes,
good stuff, though, but are they ever making it to the vagina? If you have them orally, are they getting there?
So if you're so probably to deal with, first of all, if you give it topically into the vagina, which would make sense because you're thinking that's where I want the bacteria to get to. And as you rightly say, if I take it orally, will it ever get there? We'll come to that in a moment. But the evidence hasn't said that we actually see an improvement in the vaginal microbiome. So the good bugs that we want in the good bugs that we want in the vagina don't tend to increase that much more if you are giving these probiotics topically, which is bizarre. We don't really understand why that's not the case, because you kind of are thinking, if I give a good dollop of yogurt or whatever it may be, even if it's not yogurt you bought off the supermarket shelf, but people are now packaging this up, and this is now kind of a supplement that you could buy and insert into the vagina. We have yet to see very conclusive evidence. And that's the thing. It doesn't mean it doesn't work. And we come across this in women's health so much on so many topics because there is a lack of research in this space. And I know obviously that's your whole aim with the charity, but it really does make a difference because lots of people, and I see lots of posts about this, oh, I'm so confused. There's pro this and against this. What do I do? There's a lot of misinformation. And really, I think one of the biggest topics here is that we just don't know. It doesn't mean it doesn't, and it doesn't mean it does. It's just that we don't know. And my worry is especially when it comes to something about inserting into the vagina, we've talked about it's a very delicate environment. It's got good bugs, but it can easily get disrupted. And if you then start inserting supplements, yogurts, etc., without clear medical evidence of what you should be doing and making sure you've got exactly that product, not something that is a kind of rip-off imitation that you've bought on the internet, you don't really know what you're inserting and what it's going to do. And then going back to the whole thing of their vicious cycle, what do I then do when you're like, you've got thrush with a secondary bacterial infection, we've tried some antibiotics, and you've also been using yogurt topically in the area? It's like, I don't know where to start with this because I don't really know what's causing the problem you're now facing. So some would say, okay, it's easier to shift to the oral side and ingest a lot of these products and take these products orally. The problem with that is we're yet to see evidence of that it improves the vaginal microbiome. Again, it doesn't mean it doesn't. It's a little bit grey still. I think though that you're far less likely to cause any harm. And I think that many doctors now, when they give an antibiotic course, for whatever reason, you've got a chest infection, you've got, an ear infection, or you've got a vaginal infection that requires antibiotics, most doctors are advising to start taking an oral probiotic to try and reset and kind of give a boost to the natural bugs that should be living there in all areas, in your guts, in your vagina, because they're aware that when you take an antibiotic, especially orally, you're just going to kind of do a blanket washout of everything there. So I think it's definitely is a good idea, but topical use, I'm not yet sure that the evidence is there.
Okie dokie. And speaking of things that could be very potentially harmful, even though I know there are borax suppositories, there is now a TikTok
yes.
around basically telling you to drink the borax and also to put it in your bath and then sit in it yourself. Should we be putting borax in our bath and sitting in it?
No, just no. Just no. Just no. Sometimes you just think I just have to treat some people like 3-year-olds and just be like, no, stop doing that. I just think, I'm not sure where these things come from, but my general rule of thumb is if the first I've heard of it is from TikTok, that doesn't fill me with great confidence. We go through years of medical training, researchers doing massive amount of work in this area, conferences, papers being published. But Sue over on TikTok has just launched the latest video with a nice little dance regime, and we should all jump on the trend. I just think that we just need to remember that science does have a role to play. And I think that people are so keen to help themselves, and I really understand that sentiment, but it is an exposure and exploitation of vulnerability and wanting to get an answer. And you're thinking, I'll do anything, but please beware that doing something rather than nothing isn't always the better option, especially when there's no evidence to suggest that it's going to work for your issue.
Exactly.
And definitely not cause harm. And I think when we come to medicine, that's always our number one thing. Number one, don't cause harm. That comes above actually doing good, because we don't want to be in a situation where we're causing more harm to ourselves and making things more complex.
Yeah, absolutely. Moving on from thrush. I had a couple of questions come in basically saying, I have a greenish discharge, no smell, no pain. What could be the cause of that?
Yeah, so green discharge, generally speaking, I would always say is infection, but I really do say that with a big kind of warning sign, only because I'm doing it from a very clinical basis. And if I look at everybody who I've ever seen, a true green discharge from any bit of your body is usually an infection before, unless you've proven otherwise. However, I do recognize that with vaginal discharge, there is, just because of the reality of the fact of, again, we don't talk about it that much. We don't have it within our social culture that we're all comparing vaginal discharge. And I know that might sound a bit weird, but the point is that somebody says, well, how do I, does this, it looks a bit green tinged to me. And someone else would say, well, I've always had it looking like that. And I just kind of thought it to be white. And, I think it's very important to explain that vaginal discharge is on a spectrum, like normal vaginal discharge is on a spectrum. I would say white to translucent to yellow tinge, green tinge. But I think if you're really looking at it and you think that this is green and it's, something new and something different, again, knowing what is normal for you is so important here, then I would say that that's an infection. And most discharge, well, a lot of discharge will change color without changing smell. And so you could normally have white discharge that then becomes green. And just because it's not smelly, don't think it's not infected. And so, I would be thinking about lots of different infections there. The big kind of indicator of which way you would go is really what your history is. So somebody who's had a change in their sexual partner recently and not using barrier protection, such as a condom, that would prevent sexually transmitted infections. My number one for a new green discharge would be sexually transmitted infection. If someone's not sexually active or is a long-term stable relationship, it's very unlikely, not impossible, but it's unlikely to be a sexually transmitted infection. Then there are other non-sexually transmitted infections that can give rise to a greenish discharge. But really, to be able to pinpoint and say green discharge, that's definitely going to be X, is just impossible. There's quite a few candidates there. So I would always say, if you have noticed a change in your discharge where it was once white yellowy and it's now become green, whether it smells or not, it's definitely worth a visit to the doctors to get a swab. And ultimately, that's what you're always going to need to do. You are going to need to swab it, no matter if the GP is maybe saying it's not necessary. I can't see that they would, But if I know that things are very tough in the primary care services at the moment, and so, you know, it's important that people know what they should be doing, and that would be doing a swab. I think, though, I just wanted to, when I was thinking about this talk over the weekend, I wanted to raise a point that, you know, practice is changing. And I think that it is becoming more common that GPs and nurses in that primary care setting are asking women to self-swab, maybe
Yes,
at home or pop into the GP surgery.
Yeah.
And, you know, unfortunately, I don't know, I'm not aware, it may have been looked at, but I'm not aware it has done, of whether this actually has a, you know, effect of now asking women to self-swab. In my experience, I think women who do self-swabs probably don't go high enough into the vagina. And that would be my concern. When I think about the actual process of getting a swab, when I am doing swabs, I will be doing vulval swabs that I will really be rubbing along. You know, if you think of that swab, you're rubbing along the outside of the labia majora. So really looking at the very external. I've not changed anything there. I then will open the labia and do inside. So you're really getting on the inside edge of the labia majora, and then into the labia minora, and then all around that. So a real sense of the vulval swab. That will be one separate swab. Another swab I will do, which will be purely of the vagina. So it starts at the introitus, the entrance of the vagina, because you might have something going on in the vulva and not in the vagina. And yeah, it is treated pretty much the same way. If you've got bacterial infection, you'll need an antibiotic. But the importance is if someone's coming to me and saying they've got vulval symptoms, but I don't pick anything up, I pick something up on the vagina, then sometimes you can have that mismatch and you might potentially miss something else that's going on. So it is good to separate those two.
Yeah.
And then with the vaginal,
COVID, when you were doing COVID and shoving them up the nose.
yes.
I mean, I always worried whether or not I was shoving it up far enough. I probably never did. But, you know, maybe they should have a, you know, like my pen at the bottom.
Yeah, and just be like, yeah,
you've got to put that up there to this ridge.
Yes,
That would make
exactly.
life so much easier. Take the question mark out of it.
I think that's the key thing, because often people will, and again, I think it's a key thing about the position you're in. So if you're standing, I mean, everybody's very different and everyone has different dexterity, but I would say, generally speaking, standing isn't as effective as sitting on the toilet, or the whole usual tampon application and insertion, where you've got, many women will do this, one leg up on the toilet or up on the bed and the other one standing on the floor. And in that way, you're basically spreading the legs a little bit and you're kind of opening up the vagina, but you've got to bend round. And for many women, that's quite difficult to actually get the bend to get round and then be able to put the swab up. Some women also find that position much more uncomfortable, because you're sort of going up and then you're going around and then up. And then that could actually mean that you sort of end up prodding against the vaginal wall, which can be quite painful in that moment. And so often I would always recommend to try at least sitting on the toilet, because you're sort of aiming where the vagina has actually become along a little bit more, so you can get in and up a little bit easier. But that would, you know, I do think there is a push to do more self-swabbing. And I think, you know, that isn't always going to pick up everything, especially if you are listening to this and you're thinking, gosh, I was never that thorough. And yet all my swabs came back as negative. That can be a possibility. But interestingly, I think if your symptoms persist and your swabs have come back negative, don't give up on it. And my first port of call would be to actually go and ask for a nurse or a GP more than capable to actually do the swabs for you. And that would be my starting point, to say, okay, maybe we missed it when you first self-swab. These things happen for sure. Let's just redo a set of swabs and start from there.
Yeah, that would absolutely make sense. The other thing too out of that, of course, is that you mentioned back there about, you know, sexually transmitted infections, and people don't seem to realize that old people like me do actually have sex. And
not that old.
On the old and rates of sexually transmitted infections are actually increasing quite rapidly in older age.
I know.
It seems we have forgotten to use.
Well, it's the heady days, if I may describe them as that. I know it may not be for everybody, but it is very much a feeling that, you know, having spent, you can just understand the logic here, having spent so many years probably in and out of contraception as when, you know, as to when you wanted to actually conceive rather than having an unplanned pregnancy. And therefore, when you're approaching perimenopause and you've gone through years of potentially very heavy, very irregular periods, and they quite often being the bane of your life, when you're then postmenopausal, the one big kind of golden ticket is you don't have periods. And that leaves you with this whole, I'm not going to get pregnant. Now, I just would put a kind of disclaimer here. I know that's not ideal for everybody and people are in different situations. But I think that for a lot of people, that idea of not needing to worry about when their period's going to come, not worrying about whether they've got sanitary period products with them or not, kind of goes to their head in a way of saying, well, then sex doesn't have any, you know, requirements as it once did. I didn't need to think about, had I taken my pill? Have we got a condom? Has the condom stayed intact or not? Do I need to insert the diaphragm or not? None of these things that were so often in our heads, whatever we were or were not using, are there anymore. And I think that then has led to people possibly being a bit more relaxed and free around sex. And therefore, it also is coinciding with a lot of personal changes, you know, people changing their relationships, you know, some relationships have you know, ended, they're moving on to a new partner. I think it is that sort of time in our life where that often will happen. People will go through divorce or separation, etc. And, you know, they will then start having sex with a new partner or partners and then realize that, oh gosh, you know, I'm now, the first they see about it is they've got some vulval vaginal symptom. And as you say, STIs, sexually transmitted infections, are definitely increasing in the sort of post 50, post 60 year age group. And I think that's a really important point, because people need to remember that actually barrier contraception is the only way to prevent transmission of those sexually transmitted infections. So, you know, you need to use a condom so that when you're having sex, you're not exposed to that infection that your partner may or may not have.
Yeah, exactly. Or at least have the discussion before you have the sex of saying, when was the last time you had yourself checked out? And when was the last time you had myself checked out? If it's a,
and I think that's it, becoming more relaxed and recognizing that this is part of good, normal healthcare, that you will go to a sexual health clinic, to your GP, to a drop-in clinic that looks at women's health. There's so many opportunities, but also you can just arrange for it to be an online self-swab. And I know we just talked about self-swabbing, but if you're confident with it, you can do an online self-swab that is sent directly to your house, completely anonymous. Don't worry, it's not marked up with sexually transmitted clinic to it. It's nicely in a, you know, sort of white or brown envelope sent to your house. You do the swabs and you send them off and you get a result, usually by text or email or whatever. And I think, you know, it's recognizing that this is part of good normal healthcare. And on that note, purely because I'm jumping on a Barbie bandwagon here, I have seen it. I don't know if you have.
Not yet.
Have you seen it? You should go and see it. You'd like it, Fiona. You would. I love it. And I know it's got lots of backlash, but we won't get into all of that. But it's really interesting. I was reading this article the other day about, you probably have seen, they talk about at the end of it, and it's not giving anything away, there's this nod towards needing to see a gynaecologist, like women need to see a gynaecologist. And somebody has done a deep dive as to why, you know, the director and producer wanted to put this in. And it was just about the fact that actually, you know, women's healthcare is a real essential. It's not a desirable, it's a necessity. Everyone is entitled to it. And I think wrapped up in that is sexual health. And it's the fact that, you know, you shouldn't only have to go and see your gynecologist or a doctor if you want to have a baby. And that, I hope, is a long, you know, forgotten view that actually women's health is only related to getting pregnant, being pregnant, and, you know, having a baby. That is not. I see women's health very much to be the healthcare of a woman, you know, and I deal with all of the healthcare of a woman. I don't have a clue really anymore about men. I haven't seen a man in a healthcare setting for well over 15 plus years. But, you know, it's about looking at that woman in its, you know, in her entirety, and seeing that it's not just about its reproductive function, but it's in fact about all of the healthcare that that woman needs at all the different phases in her life. And sexual health, no matter what age you are, is an essential, and people shouldn't be embarrassed or feel that there's a stigma to it, and need to be aware that, you know, it's an essential.
Absolutely. It's interesting because I got a message this morning from a woman in France saying that she contacted me a little while ago and said, I've got low libido issues. I've been to see my gynaecologist. He said that they don't prescribe testosterone in France and has given me a DHEA cream. And that's all she's been given for low libido. Sort of saying, well, what should you do? Should I come to the UK and see somebody? And I kind of thought, I thought, if I were a man, I bet you I could get testosterone in France. So I went to the European Menopause Society's guidelines for how to treat libido for women, and there it was, testosterone, and it would say exception France. So I kind of thought that, I don't know, we have a very, very, very long way to go. I felt very sorry for the woman.
Yeah, I don't even know where to start on that one. I mean, that's like a whole nother topic, isn't it? Low libido. And, you know, there's so many elements to it. And, you know, I think the issue around testosterone, where I come at it, is that there is
I did
very
say
much,
back, by the way, I did say back, it's a multifaceted and very complex issue.
and
But
that's the thing.
it's not an exception in France.
It's not an exception in France. And I think that, like, it's interesting as like, how has that come about that France has kind of gone to that place, like got to that place?
Off license, and I'm presuming, and therefore they're not willing to take responsibility for it. But apart from saying that, they just came back with, we don't give testosterone to women. So
yeah. I just think it's, you know, with all of these things, it's about being more aware of how, you know, I really want to push that people are more aware about what is normal and what they should expect, because then you can start to understand for yourself and then advocate for yourself. And that's not going to get across, you know, France's exemption, admittedly, but it is going to make you realize that what you should be getting, and that when that healthcare system can't deliver it for you, you know, what do I then do about it? But until, you know, fairly recently, many people have been in the dark. And I think, you know, when it comes back to what we're talking about, discharge, vaginal, vulvar infections, people are just like, well, you know, I know this doesn't speak to everybody, but that stereotypical, I'm married, I've been with my husband for, you know, 10 years or whatever, there's no chance of a sexual transmitted infection. So anything that I experience must just be normal and I need to put up with, because there couldn't be anything else that is going on. And it's that lack of knowledge and awareness of, like, not everything relates to a sexually transmitted infection when we come to the vulva and vagina. And there could be infections such as thrush, such as BV, but also about what's changing with that tissue as you go through perimenopause, and why, as you said, why are these things more common? Because obviously the tissue is changing drastically, because the estrogen concentration in our bodies is falling as we go through perimenopause, and that kind of production of estrogen decreases. Now, yes, it can be supplemented if you take HRT therapy, which includes estrogen, but oral or kind of you do systemic therapy, whether it be oral or patches or sprays or whatever, somehow don't do an awful lot when we're looking at the vagina and the vulva. And I know that we've talked in the past about that, of around, you know, people not being able to get topical local estrogen that you are applying to the vulval and vaginal tissue when you are already maybe on an estrogen patch, let's say, or any other type of what we call systemic estrogen. So estrogen that's getting into the body and going all the way around the body. That is very different in its effectiveness to improve the health of vaginal and vulval tissue compared to a blob of estrogen cream that you put straight around the vagina, inside the vagina, a pessary inside the vagina that's releasing estrogen, or put over the vulva. They're two very different mechanisms of action, and we have clear evidence that, you know, systemic estrogen just does not cut the mustard, and you can purely be led by symptoms. You don't need to be doing blood tests to be told your estrogen levels are this or that. We know that that doesn't make sense anyway because it fluctuates massively. You'd be led by symptoms. You know, I think the only exception I would give is if you're giving topical estrogen and it is not improving the symptoms. Now, yes, you've got to give it a bit of a chance for sure. It's not going to happen overnight. And, you know, you have to get to the right dosing and all of that with anything when we come to HRT. None of that changes. But if somebody's been on topical estrogen for 3-6 months and they're like, no, I've still got all these problems, that would be raising red flags that it's not lack of estrogen. It doesn't mean that you don't need the estrogen. And I think people don't appreciate this, and especially amongst healthcare professionals. You know, I saw a lot of this as a gynaecologist where primary care physicians, you know, GPs would have said, look, I started on estrogen, it didn't seem to make a difference, so I've stopped that and I'm now sending her to you. And I'd go, look,
why did you stop that?
Exactly. Because it wasn't making a difference. And I was like, but probably if someone's perimenopausal or postmenopausal, and we've talked about this before, you know, I can foresee a time, hopefully not too far in the future, where we really look into the fact that probably all perimenopausal women, if they wish to, should have it. They should topical estrogen, and they shouldn't wait for symptoms of dryness, painful sex, discomfort, burning, fissures, or anything like that, but actually proactively look after this tissue, because the evidence is overwhelming that as we go through perimenopause and further on, and the estrogen gets lower and lower and lower and lower, then we know that the tissue gets more and more and more delicate, drier, more sore, more susceptible to issues. And so you can see a time that maybe we might look to be giving this proactively in a preventative fashion. But if someone comes and they've got symptoms and you've started them on topical estrogen and you haven't resolved any or all of the symptoms, then yes, you need to do a workup, but I wouldn't necessarily say to stop the vaginal estrogen, because that might just be a basis of what we need. We then need to throw in a low dose, long course of antifungals because you have recurrent thrush, and we need to kind of do a two-pronged attack to get on top of the thrush and to boost the healthiness of the tissue. And when we've got the thrush under control, we can then kind of just keep with a maintenance dose of estrogen. Now, I'm not saying that this is a standard treatment. This is just a one specific treatment for a case, and it's very much a case by case situation. But it's just highlighting the point that a one size does not fit all with any types of HRT, including topical estrogen. And I think this kind of, I'll give you one thing and I'll pull it back and I'll try something else, is sometimes needed, but often it is a combination to get on top of very complex situations.
All right, I have two questions for you here. One is, sometimes I have a white discharge the morning after using Vagifem, and the other, do you have to use the topical estrogen every evening or only when you have symptoms?
Oh, great questions. So Vagifem notoriously gives a white discharge, and most of the white discharge that you would be experiencing is probably the actual Vagifem treatment, if you see what I mean. It's part of the treatment, but it also, the way that it works is, you know, one of its effects is to stimulate lubrication from the vaginal walls. So in that moment, you know, in the sort of 12 to 24 hours after using a Vagifem, so let's say you put it in at 10 o'clock at night, you go to sleep, you get up in the morning, and then you notice from that morning when you first have a wee, and then throughout the day on your underwear, etc., and when wiping, you've got more of a discharge. This is completely normal. This is what I expect with Vagifem. It's nothing to worry about. Wouldn't be concerned. You don't need to swab that. That is what I expect with Vagifem. It's part of Vagifem being, you know, leaking from the vagina, and it's also part of how Vagifem works in increasing lubrication. So the kind of leak mixed with the increased lubrication gives you more discharge. It's completely normal.
The same as well if you were using the Utrogestin vaginally and the Avestin cream, you'd expect it in bits too.
You would expect it. I know that Blissful gel. I don't know if you're familiar with that. It's a relatively newish product in the market, and rather than being a kind of tablet like Vagifem that you would insert through the pessary applicator and then it sort of expands and then becomes you get the treatment like that, the Blissful gel is actually a gel. Unsurprisingly, and in that way, what they report is that the gel basically stays in place because it's more of like a solid jelly-like thing. It's not something that leaks from the vagina so easily. So in their studies, they report that women report less discharge after using Blissful. Now, again, like everything I say in this space, it's really trial and error. Some people will use Vagifem or similar and not get any discharge, or get it and it not bother them. And that's the thing. I think so many times when you say to somebody, this is normal, they're fine. They just wanted to know if it's normal. Other people, though, they can have a lot of discharge and it affects them. I remember I used to have patients who used to say they put it in at night and they didn't really like using it because they'd have a discharge onto the sheets and they didn't like that. And so there are other products, but again, it's very much trial and error. And then the other point that we would say about topical estrogen. So this is, how can I say? So if you have a symptom and you you are therefore just started on topical estrogen, you should take it very regularly. So if we take something like Vagifem, I would normally say, look, we do a quick start, very high dose of Vagifem, something like every day for the next 2 weeks. And then typically you've kind of got this real shot of topical estrogen, and then you can start to reduce it and calm it down to something like 2 to 3 times a week. And then you can just carry on that. And, I always say to women, if you miss a dose, it doesn't matter. Nothing's going to happen to you. You may, at the very start of starting the treatment, opposed to being like 2 years in, if you miss a dose at the start of the treatment, you may feel like your symptoms, there's a little bit of soreness again. But again, it depends how sensitive you are to it and how well you're responding to it. Some women won't notice, others will notice. But you've basically got
to saying like using it every couple of nights or whatever. Sorry, I need to let my dog out. But while I'm doing that, some women are told that they must only use it 2 times a week. Can you use your topical?
So I would always say, it's difficult because I don't know why they've been told it's only 2 times a week. But if that's just because that's all the doctor knows, rather than there's some reason, but I can't think of any reason why you couldn't use any more than 2 times a week. So my typical pattern would be, when I'm quick starting someone, is every day for 2 weeks, followed with 2 to 3 times a week is pretty standard. I then say, if you feel like your symptoms are recurring, so this would typically be burning, itching, and it's not something like thrush or something that's kind of coincided with it, but you feel like your original symptoms that did improve when you started the topical estrogen has slightly started to come back, fine. Up your dose again, and you may up it to going every day again, and that's fine. I wouldn't do that necessarily every day for a long term, like talking about months and months and months, but I would usually say to women that, once you get up to a maintenance dose, you can then just use it as you need according to your symptoms, with the proviso that if that you are going to be going somewhere that is likely to make these symptoms worse. So usually hot, sweaty, or you're having a lot of sex.
Oh, you're frozen in the most important time.
Am I back?
Visually not. Yes, now you're back.
I'm back.
6 we got to, and then you froze. Self-censor.
Oh, that wasn't deliberate. So wait, that was my thread. So what was I saying? Yes. So if you know that you're going to be in a situation where you're kind of more at risk of a recurrence of these symptoms, like they're raising their head again, which I would typically say is hot, sweaty, or having a lot of sex. So the typical one that fits this is somebody who lives in the UK all the year and goes on a 2-week holiday, isn't working, kids are occupied or whatever, or they've not gone on holiday with their kids or whatever they had, they're probably ending up going somewhere hot that's sticky they're swimming a lot, they're wearing a lot, spending a lot of time in a swimming costume, bikini material, which is shocking for vaginal vulval health. Not to say you shouldn't wear it, but it does trigger a lot of discomfort and thrush infections. And so don't be surprised if you always get thrush when you go on holiday. There's nothing wrong with you. It's just because you've changed your circumstances. And usually people tend to have more sex when they go on holiday because they're more relaxed and they have more time, and and they kind of reconnect with their partner or whatever. And therefore they then come back and go, oh my God, these last 2 weeks have been hell. I've got so much discomfort down below again. And you're like, I'm not surprised, because it's hot, it's sweating, you're in a bikini or a swimsuit, and you've, have been or tried to have a lot more sex than normal. So what I say to these women is, if you know this is coming up, so you're going on a holiday in 2 weeks' time, start increasing your dose of topical estrogen to try and give yourself a little bit more of a boost in that area. Now, it's not 100% going to work for you every single time to every single woman, but I do find that if you know that you're going away with friends on a biking weekend, take it before anything that you think is going to cause some physical or kind of environmental, as in hot and sweaty, change in the vulva and vagina, then it's definitely worth upping your topical estrogen away from your normal regime.
That's good advice. And I guess also taking a couple of changes of swimsuits with you, so you're not sitting in hot and sweaty wet swimsuits.
Oh, well, you should. Yeah, I really recommend, if you are somebody who struggles with recurrent thrush, recurrent BV, and you've got genitourinary symptoms of menopause. So we talk about the soreness, the burning, the dryness, the discomfort during sex, or at the beginning of sex, anything that leads to friction, even with just wearing underwear. Do not be sitting in a wet swimming costume. I am pretty militant on that, and will say, wear that swimming costume for swimming and swimming alone. If that means you are up and you go into the toilet to get into your swimming costume, to go in the kind of hotel pool, and then you get out, you dry yourself a bit, go back into the toilet, take your swimming costume off and put your pants and your shorts or whatever you want to wear back on. And if you really want to be sunbathing in a bikini, put dry bottoms on, but don't sit in wet, chlorinated, bug-infested, pool water soaked bikini and wonder why you get an infection. Because it's just, yeah, exactly. It's walking around with a mini swimming pool that you don't know what people have been doing in.
Seawater wouldn't be as bad then, would it?
Yeah, because, well, yes, because the salt content should keep the seawater slightly healthier, but I don't know if that applies. I mean, I see women, when I go on holiday, I see women sitting on the beach and their kids are playing and stuff, and they're sitting in the sand with water lapping. And I just think, that's a recipe for disaster. You've got sand, which is going to irritate. You've got seawater, everything. So when our skin, the vulval skin, gets moist, and it will go up inside the vagina as well, that's completely normal, just like you're sitting in a bath. In the same way, don't have bubble baths and all these soaps and anything that you can sort of get to put these bath fizzes and everything else like that. Don't be putting them in a bath, because they just irritate the skin so much, and then that leads to some irritation. You haven't got thrush, you haven't necessarily got a low estrogen there. You've just got an irritation because you've got something like sand that has irritated the skin. But the reaction to that irritation, especially when you're asleep and you're not awake to know what you're doing, you then find that you start itching the labia and the vulva and maybe up inside the vagina, because it's uncomfortable. And when you do that, you then are bringing all these bugs down from your hands, and you don't know what then happens. And it really does become another trigger for starting a cycle of thrush or any other infection.
Holiday.
Anybody, I know we're doing our holiday season, so you go and enjoy your beach holidays, everyone, but don't you be sitting on that beach.
You walk up and down the beach sort of like a policeman, get up, stand up, woman. Do not be sitting there.
No, but I will say I will sit there with my husband and I'll be like, I don't think that she should be doing that. And he's like, what? He's not a gynaecologist, he's not even a doctor. He's like, what are you on about? I'm like, nothing. And you're kind of doing that spot diagnosis of, that's going to end in tears at some point. And I think the thing is, that's the thing, it's such a shame. Sorry, say again.
Ruth has just said over here she's never going into the sea again.
The sea's fine, but it's very much like, I can't think of another example. It's very much enjoy it for what it is when you're in it, but then you don't need to take the sea in your swimming costume around with you for the rest of the day. And I think, as we get older, and I'm not talking about being post-menopause necessarily, I'm just meaning that when we're, but even there will be teenagers who will struggle with this. Everyone has different skin, and when you look at anything with regard to your face creams, some people can literally dab, almost like I don't know, bleach on them, and it just doesn't. I'm not recommending bleach, but they just put any old thing on their face and it doesn't do that. And I speak as someone who knows that I can't just put anything on my face, and I will come up red and really allergic and really irritated by it. And I think people need to realize that our vulvas are just as sensitive. And so especially if you have got sensitive skin and that you've got to be careful with the different types of like elastoplasts that you put on, even, you're probably also someone with a sensitive vulva, and you've got to be careful about things like this.
Yeah. Question over here about my new favorite thing, E-string.
Oh,
do you get discharge with an E-string is the question over here.
Yeah, I mean, I don't know of that. And what I mean by knowing of that is because you get used to, when you prescribe something to a woman, does she come back and tell you that? And I know, as that's what I was saying, notoriously you do get it with Vagifem, because most women, when I prescribe it, would say, oh, I get this discharge, is that okay? I don't hear about that so much with the E-string, but I wouldn't rule it out. But if you're worried,
you could see it with why you'd get it with the Vagifem, but really, I mean, it's a silicone ring. There's nothing there that would necessarily make a discharge.
There's nothing that leaks, kind of thing. But the thing is that obviously part of, and this is the other thing, that depending on where you are in your kind of journey through perimenopause, postmenopause, if you potentially have, not noticed and or kind of pushed it to the side in experiencing vaginal dryness, then it's actually been a long time since you noticed you had a vaginal discharge, a normal vaginal discharge. You start taking topical estrogen, your normal vaginal discharge will return. That means it's working. That's one of the ways that it's working. Healthy estrogenized vulva and vagina should be producing a discharge. So often women will come back and they say, look, I've now got this discharge in my pants and I've never had that before. And you're like, you did have it. It's just you've forgotten, because it's been 2 years, 5 years since you noticed that. And it's, we also get used to certain things and we don't even clock it. And then we get used to having it, and then we get used to not having it. And then when it suddenly returns within 2 weeks of taking a new medication that you're putting inside your vagina, it makes sense to put 2 and 2 together and say, oh my gosh, something's going on. I think I've got something weird happening. And quite often it's just to say, no, it's normal lubrication.
Yeah. You'll like this. This will make you happy. Lady Gardner 64 is saying she's got her 82-year-old mother to try topical estrogen, and she's not getting up at night to go to the loo anymore. That's nice, isn't it? That's good. Can Vagifem cause cramps? Seem to get them at night after using it, but no period to show for. And speaking of that, remind me to ask you, because we're running out of time, but after this, I did want to ask one quick question about chlamydia as well, and why it has to be resolved because of pelvic inflammatory disease and those sorts of things.
Yes, good point. So no, I've not heard of Vagifem causing cramps. My only thing that I would think of is maybe the way that you are inserting the blue applicator that you have to kind of put up inside the vagina, and then you release the little Vagifem pellet. Sometimes it's, especially if you're somebody who found that you got a little bit of cramping and discomfort, or maybe a lot possibly, when you inserted tampons, or you were somebody who said that you always found it quite uncomfortable to have tampons, it could be the fact that the Vagifem drug per se, I don't think would cause cramps. I can't understand why that would happen, but it might be that the way that you're inserting it, or the position you're in that you're inserting it, is sort of triggering some sort of cramping with the neck of the womb when you come to insert it. So that's just a guess. I don't have any evidence to support that, but that would be my first port of call of trying a different position. And so if you are not sitting on the toilet with your legs sort of apart on the toilet, as though you're not like close together, but put them far apart so that you can really access the vagina very easily, try, if you're not normally doing that to insert your VagiFem and you do struggle with inserting it, or you suffer from cramps or any sort of pain on insertion, that would be my number one position to try. If you've tried that, try the 1 foot up on a toilet seat or bed or low-ish table, that sort of height, with the other foot on the ground, and then see if that is helpful.
The other thing to do with inserting these things, I mean, it's quite a long applicator, but Rita,
Yes.
I love Lauren Stryko from the US, because you mentioned, I was listening to her the other day, there's no prizes for reaching the cervix with your applicator, because it's the bottom third of the vagina where most of the receptors are, I think. So if you've got that issue, I mean, why not just put it up with your finger?
Yeah, and that's a really interesting point about, yeah, we don't really need to be going all the way up. I mean, I think maybe in some people who talk about a very deep pain on intercourse might have some benefit there, but I think most people have got the difficulties that we're talking about, that topical estrogen will help with improving estrogen in the vulva and the introitus and that first bottom third, as soon as you enter the vagina, to help them.
Yeah, although she's saying the cramps seem to come sort of afterwards, not with the inserting, but you're saying it's sort of like a residual.
Well, yeah, because you know how some people can get cramping after taking a smear or even having a speculum put in. I definitely know that will happen, and I think it's just that any sort of and people get cramping after sex as well. People get cramping during sex and people get cramping after sex. So everybody's anatomy is different, especially also if you're somebody who suffers with endometriosis or some other kind of condition that leads you to having a soreness somewhere in the pelvis. If you are then doing things like inserting tampons or inserting applicators and going particularly high with them, if you're somebody who struggles with that deep pain on sex, then you're more than likely that this will trigger a similar sort of pain. If you're not, and you've tried good positions, I'm not really sure, I'm afraid, as to why you would be getting cramping.
Interesting one. Pelvic inflammatory disease, chlamydia.
Yes.
Discharge that comes with that, and why is it so important to get chlamydia treated?
Yeah, so just very quickly, so sexually transmitted diseases, chlamydia is your probably number one, but also you've got things like gonorrhea. If you have that infection, typically that infection can travel, you've had vaginal intercourse, that infection can travel from the vagina up to the top of the vagina, through the neck of the womb, and up and out. And so basically suddenly an infection that started off in your vagina has actually spread into all of your reproductive organs, so the womb, the fallopian tubes, the ovaries, and it can actually go out into the pelvis. And part of any, when this part of our bodies get infected, they become very inflamed, and part of becoming inflamed is you get very sticky, and when you get sticky, other bits stick to it, and so this is what causes pelvic inflammatory disease. That whole organs and the inside the pelvis and that whole area there has become very inflamed, very sore, and very sticky. And even if you then take antibiotics,
like we're getting adhesions of internal organs.
And if you don't get antibiotics very quickly after getting the infection, then that infection and that inflammation and that stickiness and the adhesions can just lie there for years. People can say, I've not had sex for 5 years, so I must have got this infection at least 5 years ago, and they won't even know anything about it. And so it is what we call very much a silent condition, because you may get some discharge at the point of when you first get the infection from your partner, and then you may not notice any other symptoms until potentially you're getting, at any time point, it may be a few months or it may be a few years, you start to get pain because the adhesions is where bits of tissue are stuck to other bits of tissue. So you could get an ovary now stuck to the inside wall of the pelvis, and it shouldn't. It should be free floating and dangling and able to move. It's not like it moves anywhere, but it dangles where it needs to. Now it's stuck here, and you will get tugging pain because it's being pulled against this set pelvic wall that cannot move. And that can cause a lot of pain. And people, you know, this is one of the most common causes of chronic pelvic pain is pelvic inflammatory disease. And the other big thing is it will, as you can imagine, you've got this really sticky, stuck bits of organs that are not functioning properly. And it can very much lead to infertility, because even though your ovaries are releasing an egg each month, your ovaries, the anatomy is so disrupted, or the tubes are now blocked, the egg can't get down into the womb. And so for those two reasons, because it can cause pain and it can cause infertility, and there is no age limit, you know, so it's not like, well, I'm going to get, you know, if I get chlamydia at 60, that means I'm not worried about fertility. You should be worried about pain. So definitely, this is why, again, you can't just say, oh, you know, it's not a bother if I get chlamydia. It is. So you definitely want to be on top of getting any screening and just checking up on your sexual health for sure.
Yeah, we have natted for an hour now, and we haven't even got to what you're doing. So quickly, tell us what's happening in the femtech world, because this is where
okay.
Into. So,
well, yes, there was a point to talking about this for an hour, because what I am now working on with this fantastic company called Uvisa Health, who are based in Denmark, and they are backed with some really fantastic scientists who have identified this massive issue of vaginal and vulval infections. And they are firm believers, as am I, that antibiotics are not always the right way to go. And, you know, maybe there will be a future where, you know, we're resistant to that antibiotic, so that treatment won't work, or just generally antibiotics, as we've been talking about, and the need for probiotics and prebiotics, they're not that great to take. They can really wipe out and affect our general health and well-being. And so can we look for another treatment that will help if you do have a vaginal or vulval infection, such as thrush or BV? So they've been busy innovating and researching and developing a new treatment, which is based on light therapy. Still very much on its early days, but it wouldn't include any antibiotic. It's a light therapy that's a small device that would actually treat the infection by killing off the, you know, yeast infection or the bad bacteria that are causing your bacterial vaginosis. And so what would really help me is if people, whether you've had any infections that we've talked about tonight or not, it does not matter. And this is really crucial. I have a short, less than 1 minute survey, which is completely anonymous. But if you are a woman or a person with a vulva or vagina, that's all you need to identify as having. It doesn't matter your infection status at all. If you could complete this survey, that would be greatly helpful, because what we're trying to understand is if we look as many women as possible, we can understand how many of those women are affected by vaginal infections. So you putting, yes, I'm infected by BV, or no, I'm not, those answers are both as useful. So please, we just need as many people as possible to help in our understanding of this and try and get this new treatment out into the world.
Brilliant. Resend me the link and I will post it with these on Instagram and onto the YouTube afterwards.
Fabulous.
And is there somewhere that people can go as well, that, you know, is there a website that they can go and fill it in at?
No, it's actually only this link.
Yep.
So I will just send you the link. It's a bit.ly/BV-survey, but I'll send you the link because that's too difficult.
That's what remember. Brilliant. All right. I shall love you and leave you here, because otherwise I will lose these. And I will speak to you soon.
Brilliant. Thank you so much. It's been lovely to see you all. Thank you.
Yeah, bye.